Hello everyone, this is Shannon Perkins. I am a neonatal nurse practitioner, and we're going to spend the next 50 minutes or so discussing the challenges for infants who have gestational age-related problems. So let's begin the presentation by first of all defining what a high-risk newborn is. And so as you can see, it's going to be a newborn that has a higher mortality or morbidity rate due to conditions or circumstances associated with birth or the adjustment to extrauterine existence. We have a few factors that we need to consider when we look at how high risk a newborn would be. Obviously, gestational age is going to be the first one. The younger the baby is born in gestation, the more vulnerable they'll be. The age of viability at this point is about 24 weeks. Then we look at birth weight. Obviously, the smaller the birth weight, the more vulnerable the patient would be. And so there are a few classification systems that we look at to try to tell us how vulnerable that population would be. And that's related to both birth weight and their gestational age. You may have heard people refer to infants as SGA, AGA, or LGA. What that means is they are either small for gestational age, they are average for gestational age, or large for gestational age. Those parameters are based on growth curves at the time that the baby is born. If you are under 10%, you are small for gestational age. If you are greater than 90%, you are large for gestational age, and obviously appropriate or average for gestational age is in the middle. We further classify this kind of system by looking at, are you symmetrically one or asymmetric? What that means is that your head, the head circumference, and then the weight of the baby would fall in one category. That's considered symmetric. If you are small for gestational age, what we like to see is an asymmetric presentation where your head would be appropriate for gestational age, but your body may be smaller. That shows us that your brain got the nutrients that it needed in order to continue to progress, as opposed to where it didn't and your head would be smaller for that size. So these are all kind of things that we look at to look at how high risk the newborn is based on these parameters. Another thing that we're going to look at is the predominant pathophysiological problem that the baby presents with. Some common ones are going to be closely related to the state of maturity that the patient presents with, and may include chemical disturbances such as like hypoglycemia or hypocalcemia, or they can deal with immature organ systems like immature respiratory centers, hypothermia, hyperbilirubinemia. So we'll discuss some of these as we go through the presentation. What I want you to remember is prematurity accounts for the greatest number of admissions into our NICUs. The World Health Organization has also further classified infants based on their gestational age. And what we're going to start off with is the classifications that anyone less than 36 and 6/7 weeks would be considered premature. But we further categorize those premature infants because they present with a little bit different problem. The extreme premature baby is going to be that baby that's born less than 28 weeks in gestation. The very premature baby is going to be a baby that's born between 28 and 32 weeks gestation. And the moderate to late preterm baby is going to be a baby born between 32 and 37 weeks gestation. Why we break this out is premature babies will all share the same issues related to organ maturity and function. However, the closer they get to term, the severity of these hopefully will be significantly less. So we try to kind of gauge where the baby is in their developmental progression. You also may hear babies being classified as low birth weight, very low birth weight, or extremely low birth weight. That is also a classification that we use to help discern what we might need to help these babies prosper. Your low birth weight babies are going to be those that are under 2,500 grams. Your very low birth weight babies are under 1,500 grams. And your extremely low birth weight babies are under 1,000 grams. If you look at this picture, this is going to give you sort of a visualization of what a 24-week baby would look like. The first thing I want you to take note of is you can't really tell the race of this baby. And that's because the skin is so thin that we are actually seeing more of a red, ruddy appearance in color, because that's the vasculature that is kind of coming up and giving the baby the appearance of color. It'll take several weeks until the adipose tissue kind of starts to develop and fill in, that we would then be able to determine the baby's race. So a lot of our very premature babies kind of have this kind of red, ruddy appearance and color. Just to explain some of the things that you may be seeing on the picture, the baby's head is covered because hypothermia is a huge issue, and we lose a lot of heat in our head. So we want to keep their heads nice and covered so that they can stay warm. We'll talk about why hypothermia is such an issue later on in the presentation. The tube that's in the baby's mouth is the ET tube, and that is connected to a ventilator, which is helping the baby breathe. The silver bar that you see kind of secured to the cheeks that is holding the ET tube is what we call a neo bar, and that's where we tape the ET tube to keep it in place so that we don't have to try to tape it into their very small mouths. If you look down further on the chest of the baby, you can see some circular leads. That is cardiopulmonary monitoring. All the babies are hooked up to that. And then there is like a heart-shaped sticker sort of in the central location of the baby, and that has to do with temperature. That temperature probe is connected to the bed, either an isolette or a warmer, which provides warmth for the baby because they're unable to maintain their own temperature, and that kind of helps it regulate. Placement of that probe is important in that we can't put it over the liver because it generates its own heat, or you don't want to put it over bone because bone is cold. So you kind of want it sort of in the middle aspect as much as you can, kind of over the bowels or something like that, where it would reflect the true temperature of the baby. If we look on the right hand, that is the pulse ox. So it looks a little bit different than what you're used to in your adults. It looks almost like a little piece of Coban that kind of wraps around the baby's hand, and it has a posing disc like we talked about in 220 that will allow red blood cells to be red, and that's to get saturation information that way. And then if you go toward the middle of the baby by where the umbilicus would be, there is a catheter that's kind of coiled up and taped down. That is an umbilical arterial catheter. So when the babies are born, we can actually access the umbilical cord through an artery and a vein and place these catheters in for about a week to allow us to get blood sampling without sticking the baby. So we can do that from a UAC, and we can also follow the blood pressure tracing for continuous monitoring. And then if we place a UVC, which is not pictured in this, but would look very similar, just not with the syringe attached, and it would allow us to infuse IV fluids so that the baby would need a continuous IV, peripheral IV. So those are some of the unique things that might be new to this population of patients for you to see. The rest of the picture is going to be the diaper, which is a premature diaper. So you can see this baby's about 600 grams, the size difference that accompanies a patient who's very low birth weight and an extreme premature. And then the little legs are kind of hidden underneath. So that's sort of a depiction of what our most vulnerable patients look like. So now that you have a picture of what these very premature babies look like, let's kind of talk about some of the things we need to worry about from a physiological standpoint. Now remember, premature infants are largely dependent on their physiological state at birth and the degree of anatomic immaturity. So a 24-weeker has very different needs than a 36-weeker has, even though they're both premature, which is sort of why we break out these categories. Care is going to be relative to this gestational age of the infant that you're addressing. Okay. A few distinctive features for the extreme or very premature infant include their physical appearance, and their changes that will advance with advancing age. So if you remember, the skin was very thin. Their posture is much more laid out, kind of less flexed than you'd see with a term baby. Their hair distribution is very different. They usually have fine lanugo all over their bodies, where when we get closer to term, we have more isolation of hair to the head and certain parts of the body, not necessarily all over. Their degree of subcutaneous fat is significantly less than you get closer to term. Also, their neurological status improves with advancing age. And so our extreme premature babies are not going to be able to deal with the outside world like your term babies will. Their neurological system is still very much getting its act together, for lack of a better term, and its ability to kind of regulate movement. They're much more jerky. They have exaggerated responses to small stimulations. They do not do well integrating with all of the stimulation that they receive in the outside world, because think about it, normally their systems would be developing inside of the womb, and so that's filtered sound, filtered movement, and in a confined space so that their maturity can happen all over the body. The best depiction I can give you for some of this is going to be to look at your Ballard scoring system. I think you guys discussed that in Normal Newborn. It's going to be important for you to look at the visual depictions that are on that scoring system. To the left is going to be the most immature behaviors as far as posture, skin development, hair distribution, etc., passive movement, reflexes, all of that. And then as you move across the scale into the right side, that's going to be your most mature, your term to post-term. And you can very easily see with the little stick figures and some of the behaviors, the evolution of a lot of the systems that we're going to talk about in a second. So I encourage you to kind of look into that for some visualization of how these things are developing as the infants get closer and closer to term. All the behaviors that we talk about for the extreme premature infant improve with advancing age. And so do some of these problems. So some of the things we want to talk about would be respiratory support. Obviously, the patients are going to have, if they are born early, and especially in this category, the extreme or very preterm infant, we're talking about less than 32 weeks, they're going to have significant challenges breathing air and oxygenating themselves because they weren't ready to do that when they were born. A few things that contribute to this are going to be they have increased compromise due to a pliable thorax, meaning that their lungs don't, as they exhale, they don't hold their shape. And so it causes a lot more respiratory collapse, which then is harder for them to inhale and get air down to the bases. They have immature lung tissue and an immature respiratory center. They also have a lack of a grease that we call surfactant, which is developed in the lungs closer to term. So the earlier you're born, the less surfactant, if any, that you have. And that sort of grease that I refer to kind of helps the alveoli, the little air sacs at the bottom of the lungs, to not slam shut every time there's exhalation. Think about the garbage bag that you kind of open and close. The first time you open it, how hard it is to kind of get air in, that's sort of what happens to them. So because they don't have some of these things, they have a very difficult time getting air into the base of their lungs for gas diffusion. They also have an immature respiratory center in that they kind of forget to breathe on a routine basis, called apnea. We'll talk about that in a little while. So all of those things kind of contribute to the fact that they're going to need some respiratory support to allow lung maturity to happen, but sustain them postnatally until we can hopefully get them to where the lungs can function as they would closer to term. So they need significant respiratory support. We look at thermoregulation. Remember that skin, it was very, very thin. They have decreased subcutaneous fat, and so they get a lot of loss of heat that way. They have an enlarged head that is disproportionate to their body in some extent, and so they lose heat that way. And then they have an absence of brown fat, which allows us to kind of generate heat internally. Extreme premature infants don't even have brown fat. When you get closer to term, you have some, but even our late pretermers are not going to have significant amount of brown fat. They may go through it very quickly, and so may have some temperature instability until they can kind of regulate to their environment. So body temperature is very important because when we get cold, we go into different types of metabolism, lactic acid metabolism, etc., and that really causes the rest of our body to kind of go awry. So maintaining a good thermoregulation is very important in the care of these patients. They will have beds, just like we talked about, and I have pictures for you later. The isolettes, which kind of help to muffle sound and give better warmth, or we have the overhead warmers, which also help to do that. When we look at nutrition, nutrition is going to be huge in these infants because we need them to grow, but we're then asking their intestines to start to absorb food and do things that normally it would not have to do because mom would provide nutrition in utero. So we have to give higher caloric amounts of feedings, and we're going to have to look at how we distribute the feedings based on their gestational age. So the suck-swallow reflex that allows you to kind of suck and swallow food doesn't really happen until 34 weeks-ish, 34 to 36 weeks. So if your infants are born prior to that, we can't feed them by a bottle. They can't physically do it. And so we need to give them alternatives. So we try to start off with what we call continuous feedings through feeding tubes that we place down into the stomach through either the nose or the mouth. And if they tolerate a continuous feeding, which means a little bit of feeding every hour, then we can advance to a bolus feeding where we would give them a smaller volume every 3 hours and see how we go from there. And so the feedings are a gradual progression. Sometimes we can't give enough feedings that would support the baby from a nutritional standpoint because their gut just isn't able to do it. And so we have to supplement with IV nutrition. And that would be given through an IV administration of often TPN, which is total parenteral nutrition. You guys may have seen it. It is a combination of lipids, which would be white, kind of in a syringe or a glass bottle, with a yellow fluid that's often covered and light sensitive, and that has dextrose and protein and vitamins, and we can kind of make a concoction to hopefully provide the patients adequate nutrition. They need about 120 to 160 calories per kilogram per day to grow, because not only are we trying to sustain their nutritional status, but we're also trying to give them enough fuel to increase and grow tissue like they would be in utero. What we like to see is once they get on feedings that they gain about 20 to 30 grams a day, and we're going to go ahead and weigh them pretty much daily and kind of watch that over the course of time to see if over a week's time we're up or down. Okay, so we're very cautious of everything that goes in the patient and goes out of the patient. We weigh everything. Remember, I think you guys talked about normal newborn. After the babies are born, there is a period for the first 5 days or so where we expect weight loss of about 10 to 20% of your birth weight, but then you should start gaining that back. So that is a normal phenomenon, regardless of whether you're born premature or not. We see that, and it's a lot of water and stuff like that that contributes. A few other things I want to bring to your attention with relationship to glucose. Your premature infants are going to be highly susceptible to hypoglycemia, and that's because they have a high extracellular water content that makes them much more vulnerable to electrolyte disturbances and decreased glucose stores. So these babies are not going to be able to go without some type of IV supplementation of glucose or enteral supplementation, and that goes pretty much for all premature babies, but especially your extremes. Okay. Going down to renal immaturity. Just like everything else, our kidneys are still getting their act together as well. They have a lower GFR. They have an increased excretion of glucose and a difficulty concentrating urine, and that's due to the immaturity of the organ itself. It will continue to improve as the babies get closer to term. But they also are unable to reabsorb bicarb, the buffer that we need in case of acidosis, and so they're highly prone to a metabolic acidosis issue. Because their kidneys also are not great at filtering out things, they usually don't do well with getting rid of drugs, as far as if we have to give antibiotics or any kind of medications. So we know that the excretion time for those drugs, they kind of linger and have a longer clearance time in these babies. Kind of think about what your older clients are like when their kidneys sort of aren't as astute as they are in adulthood, how their skin is really thin. We have to worry about emollients we put on them and medications because they absorb so much, how sometimes they get disoriented because drugs build up in their system because their kidneys are ineffective. It's the same sort of premise, just based on age, okay? When we look down to some other systems I want to bring up related to hyperbilirubinemia, you guys may have talked about that in normal newborn as well. This is a phenomenon that we see based on the red blood cell breakdown. Usually after delivery, the babies have an increased red blood cell volume, and so as it starts to break down, bilirubin is released. That bilirubin is excreted by the kidneys, by the liver, and by the intestines, so either through urine and stool, or on the skin where it is kind of exposed to sunlight and breaks down that way. But if your liver and your kidneys as well as your intestines are immature, your ability to rid bilirubin is highly impacted. So we often see rises in that after birth. We have to be careful because if the levels based on the patient's weight and age get too high, that bilirubin can be deposited in their brain and give them a permanent condition called kernicterus. So that would be very deadly. So we watch bilirubin very carefully and have some interventions if we need to, if it gets too high. With regard to immunity, these patients are obviously going to be immunosuppressed by the nature of the fact that their immune system is not able to really defend itself. It's still learning. And so they are at risk for a high exposure to bacteria just by the means of being born early, and all of the things that you saw inserted and on the patient in the prior picture already sets them up for significant risk. We also have a skin that is very thin and often has issues with cracking and allowing bacteria and things to get in. So we have to be really careful. We'll talk about some of the interventions we do for that in a few minutes. And then lastly, neurological regulation. The brain is formed during the first 6 weeks of a pregnancy, and the neurons increase at about 2 to 4 months. So, and they're protected by the covering of myelin. Alterations in pressures while all of this is developing in the brain can cause risk for intraventricular hemorrhage, where blood would escape into parts of the brain where it shouldn't be and irritate the tissues and cause some issues. So these patients are very vulnerable to pressure changes, acidosis changes as their neurological system is regulating. Also, they have decreased periods of reactivity and they're sort of hypertonic. If you look at the ballad, you can kind of see that they don't really have good visualization, can't really see the human face. Their suck is weak. So neurologically, they are significantly less astute than your term infants. Okay, but that maturity will happen in a cephalocaudal direction, meaning that the arms and the face will mature faster than the lower part of the body. So now we're going to go ahead and extrapolate all of the information we just obtained from the extremely premature infant and sort of bring it over into the moderate to late preterm infant. Remember, these guys are going to have the same issues we just talked about, but probably in a little bit lesser degree, being that they are closer to term. And this is going to be the category that kind of deals with your 37-week to 32-week gestations. The large focus on this infant is that they are treated like term because physically they're about 2.5 kilos, about 4.5 to 5 pounds. They look very much like the term baby, but don't necessarily act like the term baby. So they are a category of patients that is often at risk. In this picture, it's a little bit easier to understand why these babies are often treated like a term baby. If you look at them visually, they look very similar, right? Their skin is significantly more what we're used to. You can identify the baby's race pretty easily visually. We have less equipment to deal with in comparison to size. So the baby still has a nice little hat on for temperature regulation, no respiratory support. The little leads that are on the chest are for cardiopulmonary monitoring. We have pulse oxes on both the right hand and the left foot, and that is pre and post ductal pulse oxes, which we'll talk about in 220 and maybe in a little while. That helps detect shunting at the level of the ductus arteriosus. And then we have a little cord clamp that's on the umbilicus, whereas before in a prior picture we had lines inserted. You can still insert lines even up to a term baby in that vessel if you need to, but obviously this baby is not a need. But you can see how they're about 2.5 to 2 to 2.5 kilos, about 4 to 5 pounds. And so often we treat these babies like term babies. But the things that we discussed in the prior to very extreme premature baby, all of those problems still exist. They're just much to a lesser degree. So they still remain vulnerable. We need to keep an eye out. So if you notice, this slide is pretty much the same as the first one that we discussed with regard to the extreme premature infant. These babies, however, are often discharged home because they're treated like term babies, and as a result have a significantly higher rate of readmission in the first 2 weeks of life because they may struggle with some of the same issues we talked about, especially from a respiratory standpoint. Often infants who have a little bit what we call delayed transition to extrauterine life, meaning from a respiratory standpoint, they have a little bit more fluid in their lungs. They can manifest what we call TTN, or transient tachypnea of the newborn. Or we'll discuss in 220 PPHN, which is persistent pulmonary hypertension, where the lungs, instead of having a pressure drop when the babies are born and they breathe air, that changes the flow from the way the baby was oxygenated and perfused in utero to extrauterine life to adult circulation that you and I would currently have. There's a transition there, and for whatever reason, the baby's lungs remain high in pressure, and so therefore it causes the heart to function like it would prenatally. The problem is it's not getting oxygen from the lungs, it bypasses the lungs. So it causes some issues there. So these babies are at high risk for both of those conditions, as well as respiratory distress syndrome, which we'll talk about in the latter part of the lecture. That has to do with that surfactant that we talked about, the grease that will kind of allow the alveoli to continue to open and close pretty easily. They might have a little bit of that surfactant because it is endogenously produced close to term, but they may run out faster than their body can kind of produce it, and so that leaves them vulnerable for a little bit of time. So they are at risk for that as well. We just have to make sure that we're vigilant and not be fooled by their size. Remember that they are still vulnerable in all of the areas we discussed on the prior slides. Okay. So we've talked a little bit about the preterm infant at this point, but we can't leave out the post-term infant. So remember, the World Health Organization kind of broke things down not only by preterm, term, and post-term, but also classifications in there. So your early term infant would be any infant born between 37 and 38 and 6/7 weeks. Your full-term infant is going to be any baby born between 30 and 40 and 6/7 weeks. Your late-term infant is anywhere from 41 to 41 and 6/7 weeks. And then your post-term infant is anywhere from 42 weeks and above. What I really want you to kind of focus on is what classifies preterm, what classifies term, and now what classifies post-term. I'm not as concerned as the breakout in term, okay? So we're going to talk about the 42-week post-dates infant and the challenges that they have related to the placenta that maybe is starting to decrease in efficiency. If you look at this picture, you can see some of the signs that the placenta might not have been able to keep up with its job. So this baby is often going to have an elongated appearance, possibly kind of a thinned appearance. They usually have sparse hair on their body, may have fulminant hair on their head. You kind of can't see in this little guy because it has a hat on. But if you look at the skin, significantly different picture than the prior babies that we've looked at. This skin is kind of cracked and dry because, again, the placenta's efficiency is decreasing. The house is fading, and so therefore it's reflected in the health of the baby. Okay, so we see some of that. We can also see some staining of the fingernails. The fingernails are usually longer, and they could be stained with a yellow or a green stain, which would be meconium. So remember, meconium is going to be the first stool that the baby kind of excretes. It's kind of thick and tarry. Some of you may have experienced it already. It's not fun to try to change that diaper. But when the baby is stressed in utero, so if the placenta is not providing the proper nutrition that it needs, that the baby needs, they may have some periods of stress, and that meconium is passed into the fluid, the amniotic fluid that surrounds the baby. Where this becomes problematic is when during delivery, as the babies are being delivered, they can aspirate some of this fluid, which would then have meconium in it, down into their lungs, and it would cause us significant respiratory problems. Post-term babies typically have stress in utero and are at risk for what we call meconium aspiration. That's where that meconium, that stool, which is sterile, by the way, the stool is sterile, but it still creates a lot of havoc in your lungs. You don't want that to happen. We'll talk about that sort of at the end of the lecture. But post-term babies account for about 3 to 15% of pregnancies, and we're not really sure why their labor is delayed, but we know that it is associated with an increase in fetal and neonatal morbidity in this classification of infants. So they fall into our high-risk category. Just like we looked at the picture, these infants are going to have higher problems related to that decreasing placental efficiency. The babies may have a wasted appearance or actually may appear macrosomic, and that's especially if mom has an accompanying condition called gestational diabetes or primary diabetes, where mom is exposing the baby to higher levels of sugar due to her condition, and so the babies get bigger in appearance and more kind of puffy than elongated. In that case, you have a baby that's now post-dates that's not only growing longer, but also growing bigger in mass. And so delivery is delivery issues are common. We see brachial plexus injuries or clavicular fractures with some deliveries due to the size of the baby. Obstetricians are really good at trying not to get to this point if the baby is at risk related to size and mom's, proportions. We talked about meconium aspiration, how that is something that we really worry about with this group of patients. And the greatest risk to the infant occurs during the stress and the labor of the birth, especially in prima gravidas, where mom's body is trying to figure out how to allow the baby to go through. There's something to be said about a mom who has already had a child, because your body has a little bit of memory, and so therefore it kind of is a little bit more efficient in its ability to allow the delivery to occur. So now that we talked about the different populations of these high-risk infants, let's talk about the nursing considerations that are going to be unique to them. First of all, we'll look at assessment. What should be included in your assessment? Should you cluster your care? Is frequent lab sampling an issue? Well, your assessment should be a head-to-toe assessment, and it's going to be a little bit different in this population of patients than you're probably used to, in that your hands-on assessments will only take place like twice a shift, usually at 8 and 2. And the reason for that is, remember, the neurological system of these patients is not really well established. And so stimulation can cause more stress than not. So we try to cluster our care. We try to be very mindful of doing what we can to minimize interruptions for them so that they can mimic the uterine environment that they were in so that they could grow and their bodies can mature. I do want you to remember, though, that it's not like we're just paying attention to them at 2 times a shift. We are constantly monitoring them from a cardiopulmonary standpoint. They're hooked up to monitors. We're looking at them visually and charting on that, but we're not physically going in and touching them if we can help it, except for twice a shift. Okay. Also, the frequent lab sampling can be a huge issue. Probably when you see labs being done in your patients up to this point, you're doing significantly larger volumes of blood removal than we would do in our infants. So we can do a lot of, like an entire CMP on a half a cc of blood, as opposed to 2 vials of blood for your adults. But we have the issue in that we're getting this from a significantly smaller person. So although we can do it in less blood, still frequent sampling can cause anemias, and so it's something we need to be mindful of. What are we going to do with the information, and how we monitor what we are ultimately causing the patient as far as harm. So it's kind of a cost-benefit ratio. When we look down at cardiovascular and respiratory function, we need to look at, our focus is going to be mostly on effective ventilation, because again, that's going to be one of the biggest adjustments for this baby. The situation dictates the use of either a mechanical ventilator, a nasal cannula, traditional one, which is just the one you've probably seen with your adults, or the use of a high flow nasal cannula, which, remember, that one gives us a little bit more expiratory support. It maintains air in our airways so it's easier to inhale, or CPAP. And I have some pictures of what those look like in a few seconds. Do we use the highest or the lowest level of oxygen concentration on patients? We actually are going to use the lowest in our infants, especially our premature infants, because the exposure to high levels of what we call free radical oxygen, oxygen that's circulating that's not necessarily needed for ventilation, can cause issues with developing organs, especially in their eyes. So we can get what we call retinopathy of prematurity, where the vessels in their eyes kind of, with the exposure to the oxygen, grow really quickly and can actually cause them to detach their retina and become blind. So at the bedside, maintaining the SATs of their patient around the mid-90s, 92 to 95, is okay for this population of patients. We want to decrease the percentage of oxygen that they're on so that we don't let them sit at 100. In this case, too much is not a good thing, okay? Then we look at thermoregulation, and thermoregulation has to do with maintaining their temperature in that nice zone. For them, we like 97.6 to 98.6, 99 as the highest. Kind of, we want them to sit in that range. That's where the metabolism is the proper kind. When we start to get cold, we get cold stress, and that puts us into a lactic acid metabolism, which then causes more issues with ventilation. So trying to keep them in that normal thermic zone is important. We have different types of bed based on where they fall developmentally. So we have isolettes or radiant warmers, and I have pictures of those for you in a second, which kind of help. That's where that little probe that we looked at in the first picture of the very premature infant, the little heart-shaped probe, that is connected to the bed to try and maintain that normal environment for the patient. As they get closer to term and have the ability to regulate their heat, they're weaned into what we call an open crib, where they would not need a heat source in order to maintain their temperature. When we look at infection, they are considered immunosuppressed population of patients, right? Their immune system is still trying to figure itself out, and their exposure is limited. So we have to be very careful with them. Frequent hand washing is going to be the key. They also have intensive screening of visitors. No one who's sick can come in. We meticulously clean all of the equipment. They have their own equipment assigned to them as far as stethoscopes and stuff, so that we're not moving equipment from one patient to another. And each infant is they are at risk for hospital-acquired infections, and so we are very cognizant of making sure that everybody who enters the isolettes has nothing on from the elbows underneath, that you scrub when you come to work to try and decrease any exposure to these patients. So infection protection is key. We talked a little bit about hydration and nutrition and how they are highly vulnerable to fluid depletion due to their high extracellular water content and the fact that that skin is really thin, especially in your extreme prematures. So they often have IV fluids with electrolytes in it to help maintain their hydration. We follow their I&O extremely closely. Everything that goes in and out of the patient is measured and weighed. There's very little margin for error, so we're really, like, we go down to the half a cc flush we record, okay? Optimum nutrition is very important and is the key. The calorie demand is high because not only are we trying to get them to meet their calorie demand, we need them to grow. So we use whatever mechanisms to maximize calories that are developmentally appropriate. So for instance, your extreme premature infants may have a IV that gives them TPN, which is total parenteral nutrition, and that's made up of two fluids. One of them are lipids. They're usually white and in either a glass bottle or a syringe, and that's the fats. And then they have a yellow fluid that has protein and glucose and electrolytes in it, and that's usually light sensitive, so it's covered with a brown bag. The two of those make up IV nutrition, and we may have part of that as well as enteral nutrition, where we may have a tube in that's giving them a little bit of feedings if they can't tolerate full feedings for their age. As they get closer to term, we hope to get off of the TPN, get on full feedings, and then stretch them from a continuous infusion where we give them a little bit every hour to more of a bolus infusion where we would give them, a little bit every 2 to 3 hours. And then as they get closer to term and get the ability to do that suck swallow reflex where they can actually nipple their feedings, we would go ahead and try to switch them to a more characteristic feeding from a bottle. We encourage the use of breast milk, especially in our preterm infants, because breast milk is easily digested. It provides some, by the neonatal gut, it provides some protection from an immuno standpoint, and it also is a good bonding experience. But mom is not going to be able to put the baby to breast in most cases. She's going to have to pump, and we're going to have to use that milk. Sometimes premature breast milk is different in concentration than term breast milk. Our bodies are really ingenious that way. But sometimes it doesn't have enough caloric density, so we may have to add that human milk fortifier, that little pouch that gives us extra carbohydrates and some calcium to the milk to try and make it a higher caloric density. In some cases, if moms are unable to provide breast milk, being that they are just too stressed out and they can't produce it, or they have some issue where they can't get a supply, we can use donor breast milk banks for our most vulnerable patients. If we use that, it's sort of like a blood consent that they would get, and then of course the breast milk is screened for all kinds of contagious, diseases and stuff like that prior to being allowed in the bank. We also can give formula and kind of come up with concoctions to maximize nutrition that way. We follow the weights of the babies every day, and we look at it in how are they doing for the week? Are they up for the week or down for the week? Because they're very fluid, changes a lot daily. So we kind of look at it in a week from a nutrition standpoint. Are we gaining weight over the course of the week, or are we not? When we talk about energy conservation, we're going to have to use that low stimulation environment kind of that we discussed a little bit in assessment. You want to cluster your care with minimal interruptions. We want to mimic the womb that they would have been in had they not been born early for whatever precipitative reason. The incubators I have pictures of are often covered to try and shield some light. We have some appliances that kind of help. Remember that neurological system is still developing, and so the positioning of the patients is important. And when they're in the womb, they would have boundaries constantly to kind of promote flexion. Unfortunately, when they are out of the womb, they don't have that, so we create these with little blankets and stuff. I have some pictures to show you. When we look at skin care, we look at that's the greatest barrier to infection, and we can see in our first picture how thin the skin was. Often that will become compromised with exposure to air and heat, and so a few things that we do to try to maintain its integrity as it matures. Now, regardless of when the baby was born, the skin will mimic that of a term baby after about 2 to 3 weeks of exposure to the outside world. But we may, in the meantime, provide a lot of humidity and emollients like Eucerin or Aquaphor too, that we use a lot to try and keep the skin nice and moist and prevent that cracking and stuff that you see with the term baby, the post-term baby, I'm sorry, in that picture. We don't use a lot of tape. And just like we talked about in prior slides with your older clients, how their skin is really thin, and if we have to do any emollients or any type of medications that might be lotion based, we have to be really careful with the amount, because since their skin is so permeable, they absorb a lot more of the medication than, say, your adults would. The last thing we'll talk about real quick here is developmental approach. So we're going to use that developmental approach in all of our care to try and maximize their outcomes and reduce their stress. So all the things we talked about, the cluster care, the shielding of light, is to help them sort of promote maturation of those systems without undue stress. This is just a picture of the isolette or the incubator that I talked about. You can barely see the baby in the middle, but it is like a closed plastic box that allows us to pump in humidity and warmth so that the baby can be in an environment that is conducive to a good temperature maintenance. If you look at some of the things that are in the picture, the blue light that's at the top, that's a bilirubin light. That's the light that you can put on as the bilirubin rises. Remember, it's excreted through the skin, it's excreted through urine and through stool. And so it's kind of like a glorified tanning bed, so to speak. The babies have like little eye shields on and they have maximum skin exposed, and that helps to break down the bilirubin that's circulating as those red blood cells have degraded. On the bottom part of your picture, you can kind of see this long tube. It looks like it has like humidity in it. That's actually a ventilator that the baby's on, and so that is fed into the side. You just really can't tell because the actual patient is a little shielded, but that's the incubator. This one is actually cool in that it is a giraffe, meaning that right here it allows the top to kind of come up and become a radiant warmer. So if we have to access the baby to put in lines or do some type of procedure, we don't have to move them from one bed to another. It just kind of opens up and then will collapse back down into the incubator form. So it's very convenient for the patients. This is a little depiction of the warming bag, the turkey bag that I told you we use. This one looks like a Ziploc bag, but often we'll try to do like the turkey bags that you use to cook with for Thanksgiving, because they kind of help heat stay in. So that literally once the babies are born, we put their entire bodies in it, we cover their head and just expose the parts of the body that we're often accessing, which is in this case would be placing the ET tube. This picture kind of denotes the nesting that we create, trying to mimic the womb again. Remember, the baby's neurological systems proceed in a cephalocaudal direction. What we want is a flexion that they would receive in utero. And so we use blankets, or there's some other commercially appropriate little beanies that you can put around them to try and give them boundaries, so that as they're moving their limbs, they feel a boundary, and that will calm them. If they don't, if we didn't have that there, they would just kind of keep flailing about until their limbs touch something, which eats up a lot of calories and burns energy that we don't need. Obviously, this is a time of stress for parents. Sometimes this is a known early delivery for a certain circumstance, or sometimes it's very sudden. And it's our human nature to try and protect ourselves a little bit. And so often we see anticipatory grief with parents and these high-risk infants, and it impacts their bonding. So some of the signs of parental bonding that might be lacking might be a delayed naming of the infant, where they can't kind of give you a name for the baby yet, a reluctance to visit, or an inattentiveness. If they are visiting, they're paying attention to everything else and talking to everyone else other than the infant. Or a hesitancy to engage with the infant as far as touching the baby or handling them in any way. Those are some signs that there might be some bonding that's not occurring based on the circumstance. How we combat this is we try to give a family-friendly approach to the NICU if that is possible. It is a little bit of a daunting environment if you haven't been in it before. There are a lot of monitors, there's a lot of noise, often it's crowded, there are a lot of people, and it can be very disturbing to a visitor. So some things that we'll do if we know that a mom may have a early delivery, we try to introduce her to the unit prior to the delivery so that she is not shocked by the environment. She's going to have enough to deal with, as well as the dad. So we try to involve the family to see, okay, this is a possibility of where the baby may be. Introduce the monitors, the sounds, that kind of thing. We also use primary care nursing. What that means is when a nurse comes to work, they are assigned a primary baby. And so every time they come to work, they are given that baby. It does a few things in that it allows the nurse to kind of really get to know that patient and see subtle changes in the patient that maybe someone who is not as familiar with the patient would not notice. It also gives the mom and the dad or the family a focal point of somebody that they feel like is sort of a surrogate when they're not there, and a good contact person. We have extended visiting hours in most NICUs, in that when report is given, most units are on 12-hour shifts. And so when report is given, like say from 6 to 8, you can't come in the unit. But other than that, unless there is something on in the immediate environment of the baby, they allow the parents to come and see the babies at all times. Sometimes people would come at 2 a.m. because that's when they were up at night and couldn't sleep, and they would come to the unit, and that's fine. So we try to do that. Also, we have to tell them or teach them different ways to interact with our baby. For instance, when we hold infants, a lot of people have a tendency to kind of pat their back or rub their shoulder and kind of shake them up and down to kind of calm them. Those are things that we've learned from generations of being around children. However, with this set of infants, all of those mechanisms would cause them immense distress. So teaching them how to interact with their child as the neurological system develops is going to be key. Placing your hands like on them, not rubbing back and forth, but just kind of placing your hand on them allows their neurological system to sense the touch without being overwhelmed. Holding the hands, kind of promoting that flexion, and I have a picture for you kind of at the head and at the butt to kind of condense the patient. Those are things that help them interact, allowing them just to hold your hand as opposed to rubbing them back and forth. So it takes some education. Also, a lot of the NICUs nowadays have video cameras that they can place on the patient so that the parents can see them if they're at home, if they want to kind of just look at them or have some kind of visual representation. They're able to do that. And then we encourage the parents to make tape recordings of voices and reading them books and stuff. We'll play that in the isolates low as they get closer to term to kind of introduce their voice, etc. We also have kangaroo care, which is exactly what it sounds like. A kangaroo carries its baby in a pouch, right? So what kangaroo care does is we allow the parents to have the baby put on their chest, skin to skin contact, so the baby's just in a diaper, and they lay on their parent's chest, and that way they are kept warm because the parent's body heat diffuses into the baby and keeps them warm, but it allows them to smell their parents, to feel their parents in multiple senses, and it also promotes bonding for the mom and dad to be able to feel like they can actually contribute to the care, because the traditional things that they would be doing for a term infant who isn't presented with any of these challenges, they're not able to do in this environment. So we try to go ahead and do as much as we can to promote their bonding. I have some pictures of kangaroo care for you in a minute. Nurses are often a huge support system for the family unit and play an intricate role in this parent-child bonding. So you at the bedside are key. This slide just depicts the different types of handling I just discussed. Family-centered care, how we have them to lay their hands on the baby to touch them as opposed to rubbing, just a different way of interacting. This is a picture of the kangaroo care. The baby's laying on dad's chest. They are able to have some respiratory support to do this. The only thing that often limits their ability to participate in kangaroo care is if they have umbilical central lines. We usually don't move them with those because the chance of dislodgement is high. Once those lines come out, we can then start to do kangaroo care. And typically, patients will have higher saturation levels and require less oxygen when they are engaging in kangaroo care with their parents. So it's pretty cool. I put this slide in there just to remind us that obviously this 15-minute discussion is an entire medical discipline. And so this is merely an introduction, but you can see that the parents who experience this have a lot of challenges just understanding that the way to interact with their patients, all of the medical things that go along with keeping their patients viable and hopefully maximizing their health journey. So this is just, it was a post about a mom saying all of the things that she had to learn, and that's just a few. So being a supportive person is going to be necessary as the bedside caregiver, because the parents are really going through not only this worry and stress of, is my baby going to survive, but how do I navigate this? I don't know if I'm ready or not. So being their advocate is important. Few things that I wanted to bring to your attention related to complications of premature birth that you might hear in these units. So the first complication I want to discuss with you is the respiratory distress syndrome. I referred to it earlier in the lecture a little bit as surfactant deficiency. And so this is a disease that happens when we don't have the proper amount of surfactant to keep those alveoli, the little air sacs that provide gas exchange, open during the respiratory cycle. Remember, not present in an early premature baby. Their bodies don't make it yet. As they get closer to term, endogenous production of surfactant continues or starts, but is kind of low. When you hit term, you should have a significant reserve. The at-risk babies that we talked about, those late premature babies, have some surfactant, but kind of use it up really quickly. And there is a lull between when their body can kind of churn it out and when they use up their stores. And so that's where they typically have that TTN trouble that we discussed. Some things that contribute are the things we talked about earlier, the pliable thorax, the fact that the lungs sometimes are underdeveloped and these alveoli are present as far as formed but not matured to function, and then the lack of that surfactant or grease. What your patients look like, they're going to look air hungry. They're usually tachypnic initially, so a respiratory rate greater than 60. They may have dyspnea or shortness of breath. They have retractions, usually intercostal or higher. They may have some crackles, display grunting or nasal flaring. Remember, these are going to be obligate nose breathers, so the only way to get air into their respiratory system is through their nose. They can't coordinate getting air in through their mouths. So flaring would be, I'm trying to get more air in. That's a sign of respiratory distress. Expiratory grunting is that kind of like singing noise that is actually the infant trying to keep air, a little bit of air in the lungs so that they can reinflate them. So it's not, they're not singing, they're having respiratory distress. And it's very rhythmic and kind of a lower pitch sound. As the distress increases, they may get pallor and cyanosis. They may experience periods of apnea. And apnea is a cessation of breathing where we don't breathe for more than 20 seconds. This is very common in this population, remember, because they have immature respiratory centers where their brain kind of forgets that it has to keep breathing because it's not supposed to be doing that yet. Okay? And then as this condition progresses, we get deteriorating vital signs, central apnea, which is where your brain just doesn't breathe at all because your CO2 levels are getting too high, and temperature instability because the whole body is now really not doing well. We hope to intervene before we see all that. Diagnosis of the syndrome is actually done by x-ray, and there's a particular reticular granular pattern that you see. It looks like kind of broken glass on an x-ray. I just tell you that for pure knowledge. Obviously, that's not something that you are responsible for at the bedside, but that's what we look for in x-ray. The treatment or nursing care related to it is we need to maintain adequate ventilation and gas exchange. And so respiratory support is going to be dictated by the case presentation. The maximum support would be a mechanical ventilator, and we have special ventilators. We have traditional ventilators, you guys will talk about more next semester, where it gets more of an inhalation and an exhalation breath. Or we have high frequency ventilators where the air kind of pulses in the patient and then passively comes out. The patient's respiratory rate is up at like 300 to 400 breaths per minute, and their chest kind of vibrates. So that's sort of a different mode that you have probably not been introduced to. That's called high frequency oscillator ventilator. We have the CPAP or the nasal cannula. I have pictures for you in a minute that can all be used. Remember, with the use of oxygen, we want to give enough oxygen to keep our SATs sort of in the 92 to 95 range, but we don't want to give extra because it can cause issues with the baby's eyes, especially if they are in that extreme prematurity category. Maintaining good temperature, acid-base balance, so keeping your ABGs in order, your electrolytes and hydration are going to be important for the overall health of the baby. And the good news is that for especially your late premature babies or even your preemies at this point, once they're exposed to oxygen, their body sort of gets the idea that they need to start producing this. And so the disease gets worse in the first 48 hours, and then usually after 96 hours, the body starts producing surfactant and it gets significantly a little bit better for especially your late premature babies if we can bridge that gap. There is a medication now called surfactant or Baractant that we can give via an ET tube. So we would intubate the baby. We would put this medication, it's like a liquid, down the ET tube. It's based on weight as to how much they get, and then we kind of rotate them from one side to another. We give it in little amounts to try and get it to disperse all over the lungs. And we can give it up to 4 times in the first 48 hours of life. As the bedside nurse, you would not give that medication, but you would be responsible for watching the patient after. And what you want to pay close attention to is what the saturations of the baby are on the support that they're on and what their respiratory effort is. Because when we give surfactant, think about what it does. It should then coat those alveoli and kind of help them to open up and accept air and give gas exchange. So you would expect your patients to have improved saturations and improved respiratory effort. And so what we want to see is that after we give the meds, when we see that, we want to turn down the support, either the amount of ventilation support we're given through the ventilator, so coming down on the pressures, or even the rate, and coming down on the amount of oxygen, because we don't want to overstretch the lungs, because now they're so much more compliant than they were before. We can actually cause them more harm than good. Okay, so evaluation of once the medication is given, following those parameters is going to be a very important duty for the bedside nurse. These are just pictorial of the different types of oxygen delivery systems. So on the left, we have an oxy hood, which literally just is oxygen pumped into this little plastic bubble. So it increases the amount of oxygen surrounding the face of the baby to increase the amount that they would give with each breath. So often we'll do like a 30% oxygen hood or 40% oxygen hood. Again, just a little supplemental oxygen, but the baby is doing all of their work of breathing themselves, and that they're generating their own rate, their own pressures, etc. To the right, B is going to be your traditional nasal cannula, same thing, just providing some supplemental oxygen, but the baby has to have their own intrinsic respiratory drive. These are just some pics of the high flow nasal cannula and CPAP. The high flow is at the top. Again, looks very much like a traditional nasal cannula, but a little bit thicker presentation. The high flow allows us to give higher pressures based on weight than just the 2 liters that we could give for a normal nasal cannula. And it also allows us to give a little bit of pressure support, so that when the babies breathe out, that maintains some air in the airway to help it inflate a little bit easier. CPAP on the bottom, you can tell they don't like that very much. It's not very comfortable. They get out of it all the time. The little hat has the tubes that hold together, and that provides the same amount of respiratory support or similar to the high flow, in that it tries to maintain air upon exhalation so that the babies have an easier road to get air into the lower bases of the lungs. In both cases, both babies still do have to have an intrinsic rate in order to be on those appliances. This last picture is a mechanical ventilator, and so what you see is the look at the face of the baby. There is that NEA bar. In our original picture, it was silver. This one is a different maker. It is a yellow, and it holds the ET tube in place. It's going down into the trachea of the infant. The tube is then attached to the ventilator that you see on the right-hand side of the picture, and that is providing a rate, pressure support, and oxygen to the baby. Okay, so that's what the mechanical ventilator might look like. I just briefly want to discuss some other premature complications that you may see in this group of patients. We already talked about it. Apnea prematurity is a cessation of breathing for more than 20 seconds. We see this in our premature babies due to immature respiratory centers, and usually the closer they get to term, the more they can kind of grow out of it as their respiratory centers mature. Some of the things that we can do is, if a baby experiences an apneic episode, mild stimulation, just kind of patting them on their butt or their back, sometimes can kind of spark them into, oh, hey, I need to breathe, and we'll get recovery that way. If we have to give them some medications, we often will try theophylline or aminophylline, or, which you may have had this morning, to wake up, caffeine. Either one of these medications can kind of help stimulate the respiratory centers until they reach maturity. As the patient, if they are put on these medications, as the patients get older, we try to let them outgrow the medication as opposed to weaning it off. So what we'll do is leave it at the steady rate, kind of watch it over a few weeks. As they get older, we'll go ahead and let them outgrow the medication. So that's apnea of prematurity. BPD, for those of you who are in 220, we discussed this is a chronic lung disease similar to your COPD patient, where because of some of the things we have to do to allow premature babies to live, putting them on mechanical ventilation, using that ventilation to get gas diffusion sometimes has a byproduct of making the airways very stiff and scarred. And so those patients incur this chronic lung disease. So our goal is to try and get them off of the support as soon as possible and to use mechanisms that do not cause as much lung injury. Neonatology is relatively new, started in the 1980s, so we are better than we have been, but we're still getting our information to improve the outcomes of care. So unfortunately, BPD is still around, but significantly less than it used to be maybe 20 years ago in incidence. Necrotizing enterocolitis, I referred to, I think, with feedings a few slides ago. This is sort of, I kind of call it the cancer of newborns. We really don't know what the causative agent of it is. However, we know that it affects the intestines. We know that it is associated with some type of what we think a hypoxic event that the gut experiences. And when the babies have food in their bellies, it can cause this bacteria to perforate into the intestines and get pockets of air. It's called intestinalis dermatosis, and then that can burst and actually cause like necrosis in the bowel. It happens sometimes very quickly. Your patients look fine, and then all of a sudden they have this gray abdomen and have a decline because of a total necrosis of their gut. So as the bedside nurse, things I want you to take from this is we want to prevent it. And the way that we do that is by catching signs early. So you're going to look, if you have a patient that is premature or on mechanical ventilation or anything like that, you want to make sure that their feedings are going well. You look for emesis, increases in abdominal size, and we measure abdominal growth sometimes on these patients. Visible bowel loops where we can see kind of like sausage loops on the abdomen, stools that have blood in them. Any of these signs that would tell us that there's feeding intolerance are signs that we need to look at. Often what happens is we'll get these signs, you'll report them to your provider. They'll stop the feeding and then do some x-rays to see if the gut looks enlarged, or in the worst cases, if there's air in places that there shouldn't be in the abdomen where we think there has been an opening of the intestines. So at the bedside, your key is to report signs of feeding intolerance extremely quickly so that we can hopefully prevent this. If we can catch these warning signs early, we often will stop the babies. They'll be placed NPO for a few days while we let the kind of gut calm down, and then we gradually reintroduce feedings if we're able to catch it. All right. Retinopathy of prematurity, we already discussed. This is very characteristic to your low birth weight infants, your infants under 2,000 grams at birth and under 28 weeks at birth. They are at the highest risk for this. And so if they are on oxygen therapy, we want to keep them at the lowest level of oxygen necessary to maintain their sats. So we kind of want to wean their oxygen as much as possible while maintaining their sats in that 92, 95-ish range. Bedside nurses have shown to decrease the incidence of ROP by 50% just by titrating the oxygen. So remember, not all people want 100% oxygen and 100% all the time, okay? Acute intracranial hemorrhage, we refer to that, or IVH, intraventricular hemorrhage, is what we talked about, how in our extreme premature babies, especially the germinal matrix, which is the vascular part of the brain that's still trying to solidify, is very prone to pressure changes as well as acidosis. And so when we have either one of those, there is a risk that those blood vessels can become very permeable, and we get blood that extracts into parts of the brain where it shouldn't be and irritates those tissues. This can be devastating for your patient, especially if it progresses into the white matter. It leaves long-term effects and is not able to be treated. So you can get hydrocephalus, you can get permanent brain damage, you can get CP. So what we want to really pay attention to is the signs of intracranial hemorrhage at the bedside. Does your patient have a sudden drop in blood pressure? Do they suddenly get pale and anemic and apneic? These are, do they have a sudden onset of acidosis? These are all signs that they could have some type of intracranial bleed. So those are things you'd want to take note for at the bedside. Is their H&H dropping? That kind of thing. And usually this is a sudden onset. This is not something that happens over, period of time. Think about like the blood vessel would burst, and so you would see this very rapid deterioration. Patent ductus arteriosus is the last one on the list. This is one of the fetal connections that allows the nutrients to reach the baby from the placenta, but once the baby's born, it cuts off pathways that bypass the lungs in utero, and now we need it to close so that the adult circulation pattern can form. For those of you who are in 223, we'll talk about it at length, but in that case, when it's patent, that means it didn't close like it's supposed to, and it allows blood to bypass the lungs, and this causes a big problem because that blood is not oxygenated, and so your patients can have some issues with their ability to keep up from a respiratory standpoint. You'll cover it more in 223, but I mean in 220 than 223, but that is something that we struggle with in this population of patients. We're almost done. I just wanted to bring up two complications that we often see with that post-term baby that you may encounter. One of them would be meconium aspiration, and the other one would be persistent pulmonary hypertension, or PPHN. I think I alluded to this in prior discussion, but the meconium aspiration syndrome is where the baby, for whatever reason, has stress in utero and excretes a meconium stool into the amniotic fluid. When the babies are born, if the fluid is stained with either a yellow or a green color, that is often the sign that meconium is present in that fluid. And during the delivery process, if it is in the nasal pharynx, there is a risk that when they take their first breath, they can then aspirate that down into their lungs, which the meconium is a very thick stool. You can kind of see it if you've ever changed a diaper, and it's dark green and it's very thick, and it creates in the airways what we call a ball valve effect, very similar to your COPD patients, where it traps air below and above where it is, but doesn't allow that air to move back and forth, and so we have trouble with ventilation. Unfortunately, once it's ingested in the airway, there's no way for us to get it out of the lower airways, and so our management is dictated by the presentation. For instance, if the meconium is very thick and the baby is still in the delivery process, sometimes they'll do what they call an amnio infusion, or they'll try to infuse fluid into the amniotic sac so that they can dilute the thickness of it in case of aspiration. But when the babies are born, their heads who are affected with meconium, once the head is delivered, the physician will probably try to aspirate any contents that would be in the oral pharynx of the baby before delivering the rest of the body, in an effort to prevent them from taking that first gasp and aspirating the meconium down the airway. If, however, they are unable to get it, or it migrates at our best efforts, sometimes it gets dislodged. If the baby after that initial suction starts screaming, crying, then we just go ahead and monitor the baby and see how it goes. If the baby is limp and does not make respiratory efforts, then we immediately rush the baby from the delivery over to an isolate, or a radiant warmer actually, and the provider would intubate the baby with an ET tube, hook that ET tube up to suction, and then try to evacuate the airway before the baby would aspirate it into the lower lungs. We do that until the baby either makes attempts to breathe, or the baby needs a permanent ET tube placement because they are already suffering from a respiratory depression. Okay, but what I want you to look for in these circumstances is the baby meconium stained from delivery? Maybe we didn't need to intervene, or you're taking care of the baby in a nursery who might have had meconium exposure but you think is okay. If they have an onset of tachypnea, meconium staining in their fingernails and stuff, where we know that there was some exposure, if they start to get hypoxic, acidotic, or maybe hyperventilate initially and then start to hypoventilate, those are all signs that maybe some of that meconium made it down into the lower airways. The way we would diagnose this is through an x-ray, and it shows this bubbled appearance with the air trapping with the meconium down there. Unfortunately, our treatment and nursing care is supportive management. We can't, once it's aspirated into the lower airways, we have to wait for it to absorb. And so we try to support the baby as much as we can with respiratory support. In the worst case scenario, if they continue to deteriorate, then we would have to put them on heart-lung bypass, which is called ECMO, extracorporeal membrane oxygenation, which basically would let the lungs rest until they were able to clear the meconium through absorption and then reinflate the lungs. If you need ECMO support, the longer you are on the support, the less your prognosis, because of the length of time that you're on it. So if you're going to go on it, you want to be on it for a short time, not days, definitely not weeks. Okay. I have some pictures for you on the next slide. So this is sort of a picture of a baby who has been exposed to meconium at birth. You can see it around the umbilicus and sort of the upper leg. You can see that yellow or greenish staining. The baby is being intubated as we speak and suctioned. Has significant probably respiratory distress, but that's the staining that you would see. The last complication I'm going to talk about real quick is persistent pulmonary hypertension, or PPHN as it often is called. It's also known as persistent fetal circulation, and that's pretty much what it is. The circulatory pattern tries to mimic what it did in utero when the lungs were not being utilized after the patient has been born, where we know once you're born and mom and the placenta are no longer doing the work for you, your lungs have to play a huge part to oxygenate you, right? And so if they don't inflate and their pressure stays high, then blood assumes its pathway that it's used to and doesn't convert to what we need it to sustain you postnatally, and so it causes a huge issue. The clinical manifestations are very much what you would expect for somebody who is in severe respiratory distress. Your patient is hypoxic, they have marked cyanosis, they are tachypnic, they're grunting, they have full retractions, they have oxygen saturations that are very low because their lungs are not being utilized. And if your blood doesn't go to your lungs to get oxygen, your saturation levels are pretty low. They have decreased peripheral perfusion, and if it persists, you go into a shock. Okay. These are the sickest of the sick patients. Their inertia ratio is usually 1-to-1, and if they go on ECMO, like we talked about with meconium, in a worst case scenario, it's often 2-to-1. Their diagnosis is confirmed by X-ray, and that we are not X-ray, a cardiac echo, and that we can see shunting that's not going to the lungs; it's shunting away from the lungs. If you're in 220, we'll go through this pattern a lot more. You'll have a greater understanding of the heart in that class, but I just kind of want to give you the basics of the condition here. Some things you might see with treatment would be supplemental oxygen and ventilation is often required. There's a few drugs that we would do. Dopamine and dobutamine are often for blood pressure support. Sildenafil is a drug that was given or manufactured to drop the pulmonary pressure, so to make pressure in your lungs decrease. That would allow the circulatory flow to kind of regulate to the adult circulation. So it could be used in this group of patients, as well as inhaled nitric oxide, which is a gas that we would put in the ventilator circuit that helps to drop the pressure in the lungs. If none of those things would work, then we could actually use the heart-lung bypass we just discussed, that ECMO machine. If you're the nurse taking care of this patient, obviously you need a higher level of skill than you get right out of school, so there would be significant training involved. We still practice the same principles that we talked about as far as minimizing stress, touching the baby only when necessary, but obviously the level of care and demands increase. This is a little pictorial of what we just discussed. So the baby is in the radiant warmer, the head is facing us. The two cannulas that you see coming out to the right are actually the heart-lung bypass. So the patient is on ECMO. The machine that's on the right side of the picture, opposite of the nurse, is going to be the ECMO machine. So those cannulas run blood out of the baby through the machine, which serves as the heart and lungs. So it infuses oxygen into the blood and then puts it back into the baby's circulatory system. So basically giving the heart and the lungs time to rest, so that when we can get them to start working again, hopefully the lungs will inflate, the pressure will be different, and we can get a normal pattern to occur, or a desired pattern to occur as far as from the circulation standpoint. On the opposite side, on the left side of the picture, you see like a long tube that goes to a box. That's a high frequency ventilator. So that's the ventilator I talked to you about, where it deliver blood, breaths at like 300 to 400 times a minute, where the babies vibrate back and forth. It helps to maintain pressure in the airways to try and get the lungs to expand, but not cause extra damage. And the little box in front of that is actually the nitric oxide gas that's being bled into the ventilator to try and help with the pressures. Well, that does it for our lecture. Sorry I went a little bit over, but it is, again, an entire discipline that I try to give you a brief introduction in these few minutes. If you have particular interest or have anything that you need clarification on, please feel free to reach out to me by email. And as far as testing is concerned, what I want you to know is basically what the nurse would be at the bedside looking out for. What kind of things would we do differently for premature infants? What kind of things would we do uniquely for our postpartum infants? What kind of signs and symptoms are we watching for decline? The uniquenesses to the population are where I would like you to focus your study efforts. I hope you've enjoyed this, and let me know if you need me. Thanks. Bye-bye.